This week on the BackTable podcast.
I still can't believe it happened, but I was between cases one day, and so early on, walking down the hall in the Röntgen Institute, walked by the place where they were doing the angios, and on the monitor in the room, I could see a catheter down a leg. I knew it had to be an angioplasty, so I walked in and said, "Hi, mind if I watch?" Because I'd never seen one, and so he says, "No, come ahead." So so he put the wire through. And then catheter comes down. Okay, I understand that. But then a balloon goes up. Ooh, I didn't know they were using balloons now. It turned out that was the only place in the world that was. And so the balloon then, after a while, goes down. Catheter comes back, squirt, arteries open. Really cool. Wow. So the guy's taking off his gloves. And I said, "Gee, that's really neat. I'd never seen an angioplasty before. Hi, I'm Dave Kumpe." He says, "Hi, I'm Andreas Grinzig."
Hello, everyone, and welcome to the BackTable podcast, your source for all things IR and endovascular. You can find all previous episodes on our podcast on iTunes, Spotify, and BackTable.com.
This episode is brought to you by Boston Scientific. Boston Scientific has just released the legacy study data confirming TheraSphere as a new adjuvant or standalone therapy in treating HCC. 98.6% of patients responded with just one treatment as TheraSphere, with 93% overall survival at 3 years. Visit bostonscientific.com/legacy to learn more.
This is Peder Horner as your host this week, and I'm very excited to introduce our guest today, neurointerventional radiologist, Dr. David Kumpe. Thank you very much for being here, David. Good morning.
Thank you for having me.
You've been around for quite a while, and you have a lot of things to share with us regarding the history of IR and your wonderful career. Could you just tell us a little bit about your background, and then we'll go from there.
Yeah, usually I like to look forward, not back, but I do have this presentation on some of the stuff we'll talk about, and the residents and fellows like it, so maybe it's okay, but that's the way old people talk. This is the way things used to be, Anyway, I grew up in northern Kentucky and went to school in Ohio at Oberlin. And so when I went to medical school, it was Harvard, and Boston was a big change. During medical school, I was always going to be a surgeon. And then sometime in my, I think late in my third year, I met a really inspiring teacher, Lucy Frank Squire, who got me interested in radiology, and I enjoyed it. And so I thought maybe that could be an alternative. Now, this was the era of Vietnam, and that forced you to make a decision in medical school, because all docs were going to be in for 2 years. You just were not going to get around that. You either took your chances, but then got drafted as a general medical officer, or right. you enlisted and got a deferment so you could finish your residency, then go in as whatever specialty you were. Wow. And I was really on the fence about radiology versus surgery, but you had to choose your specialty. And so I took a flyer on radiology. And I did a surgical internship at Columbia, then got back to Boston, the MGH, for residency. And one interesting side note, how perverse my outlook had become. After I got back to Boston after that year in New York, I immediately noticed a slow and easy, relaxed pace of life in Boston.
Okay, and how did you then finally get interested in IR? I mean, was this even a field at this point?
Well, hell no. I mean, it was at that time, you never heard of this, but I was a general radiologist. That was my residency. So It's all x-rays, right? So I had 2 years of diagnostic radiology and 1 of radiotherapy. And I liked angiography because it involved procedures, and I was interested in that. But at the time, man, the MGH was a backwater. This sounds almost unbelievable, but on my angio rotation, I had done 1 angio. 1.
Wow.
My second angio, I was the staff, and I was assisting in teaching another doc who had no angio experience, and we did a thoracic aortogram on a 23-year-old looking for an aberrant subclavian, which she had. I mean, what could go wrong with that? Hey. I did finish residency without doing any major damage, and one of the really most fortunate things in my entire life is met Rosemary, and we got married before we left for my military. And she was our physics teacher. She was in charge of getting us through the residency and getting us through the physics section. And it's always good to marry somebody smarter than you are. And boy, did I ever. And she's taken care of everything ever since. She's really responsible, giving me all the time I needed to develop this career. After residency, I go to NIH. I had a cord deferment, which meant Navy, and that's where the public health service is. And I got accepted as a fellow or whatever you want to call it at NIH. And this was a great assignment. I mean, this is as good, I think, as you could get with a military hitch. And so we were at the clinical center. Now, this is this giant brick building. At the time, it was the largest brick building in the world. I don't know if it still is. And it's this huge, it's a hospital, but that's mostly research and labs and stuff. So proportionally, there were very few patients there. We were doing the diagnostic radiology for those patients, and they had all these different specialized diseases. There were 4 of us every year, of the fellows, and that's where I really got my first training in angio. The guys who are now second year, during our first year, they were all really sharp. This was a plum assignment, and these were all really top flight guys from top flight programs. And 2 of them were really interested in angio, knew a lot, and they're the ones that first taught me something about angio. But that's where I also, that first year, did my first interventional case. So it's...
what was your first interventional case?
It's Friday afternoon, and the surgeons come down, and they got this lady with a GI bleed. Now, she's on there. They had a hyperparathyroidism program, and this lady had really, really severe hyperparathyroidism, skinny and weak and all sorts of stuff, and she commenced to bleed. And was bleeding out, and the surgeons really, really didn't want to operate on her. But sure. They at least wanted to know, could we tell where the bleeding was? And I knew about angiography for GI bleeding. And so I said, sure, we could do that. So I did an inferior mesenteric, and lo and behold, is this beautiful, she didn't have much bowel motion, we could even subtract it, bleeding point in the sigmoid. And but like I say, they really, really did want to operate. And I knew about the work that Stan Baum had been doing with infusing pitressin for GI bleeds. So I suggested this to him. They said, oh, yeah, if you could do that, hey, that'd be great. So I called the MGH trying to get hold of Stan, and I got Chris Athanasoulis, and he just gave me the cookbook. He gave me the recipe. You give the pitressin 0.4 per minute, and you do that for, 10, 20 minutes. Then you cut it back to 0.2 per minute, and eventually you turn it off. And so we did that and did a follow-up angio in, I don't know, half an hour or something like that. And it was beautiful. The right size arteries had shrunk down. The bleeding was gone. And it stayed gone when we finally turned it off. And we had just saved a life with a catheter. And, man, I was hooked. That was, oh, boy, this is what I want to do.
Yeah, I mean, it's amazing. We forget the microcatheters haven't always been available, right? And coils and all these things that we take for granted these days. Neat treatment to be involved with, have to offer. Wow, what a great story. Wow. Well, at that point, did you have any mentors that come along this time?
Well,
you have kind of the field was developing, and you have mentors that some people have experience in one area or another. Can you maybe explain some of who your mentors might have been?
Oh yeah, did I luck out with mentors? I had some of the most prominent and best people I could have possibly had. I'm almost an historical artifact because I had so many of these guys. So the first was John Dotman. Now, he came back to NIH my second year as the chief of radiology, and he was one of the real early giants of interventional and of diagnostic radiology. And I had a year with him. Now, there were 4 of us each year, the guys who came in the second year, so now there are 8 of us. And of that whole 8, I was the only one who liked angiography. And so pretty much I had John to myself that year teaching me stuff. And I learned spinal arteriography and adrenal vein. That's 1975, man. So spinal arteriography, adrenal vein sampling, parathyroid sampling, venous sampling, and arteriography, parathyroid arteriography, ablation, mediastinal adenomas with a catheter, and some early embolization. Wow. And, that was really sophisticated for the time. I was able later, after I left NIH, John and I became friends, and I could ask him for advice, and I did, all up until he died of myeloma. He's my real hero. Wow. And the stuff that he did, people are, even today, just constantly rediscovering. I was at a SIR workshop with Scott Trertola on adrenal vein sampling, and he'd gone back into the literature and was just amazed at what Dotman had published. He was talking about that. And then one of my other ones, one of my real current bugaboos right now, is that embolization of mediastinal parathyroid adenomas has virtually disappeared. I've been trying to get this going again by giving lectures. I've been able to do that, talk about it at WAIS, but not at SIR so far. And it's just disappeared. And it's now really quite much better with microcatheters. And it's a procedure that's been around 40 years. And nobody's doing it. And so I really want to get that started again.
That's funny, Dave, because I've done 2 in the last couple months. So.
Have you really? Yeah. So you're doing it here? Yeah.
We use alcohol in the Pyadol. It works great.
Yeah. Excellent.
I cannot fathom how you would do that without a microcatheter.
You had to push hard on the catheter to get it to the right place.
That's unbelievable. I mean, were you guys steaming catheters to make?
Oh, sure.
All that right? Yeah.
We'd have pigtail catheters for aortograms, and you'd use catheters multiple times. So when the tip got a little crummy, you would cut off a little of the tip of the pigtail and reuse it. Oh. And one of the cases I saw, I don't even know where this case came from, that somebody had shaved the thing off so the pigtail was almost more like a C than a pigtail. And they had done an aortogram, and the damn thing popped back and then selected an intercostal. And it was the most dramatic example of seeing an artery of Adamkiewicz that you ever saw, ionic contrast, and the patient never walked again. Right. Just,
Well, thanks for pronouncing that name the correct way, too. Well, good. Well, were you always at the University of Colorado? I mean, you weren't, right?
No. Actually, I started at the University of Maryland. Rosemary was already teaching physics there. Actually, I did my first neurointerventional case there. This was a 12-year-old kid, auto accident. There was a CC fistula. And the neurosurgeon, Ron Paul, had tried to fix the thing, and it hadn't worked. He was a really open-minded guy. He came down to radiology and asked if we had any ideas. Yeah. So I went off to the literature and found this article by Prolo and Hanbury. And John Hanbury was the chief of neurosurgery at UCSF at the time. And they had this procedure where you would you'd do a cut down of the carotid and take a Fogarty catheter and put it up the internal to where the hole was, put it through the hole into the cavernous sinus, blow it up, pull it back against the hole, and then sew it into place. So you then fold over the shaft, cut it off, and sew the two sides of the shaft together, and then sew that into place and close the carotid. And so I suggested this to Ron. He said, well, let's try it. So we went off the OR, and we were listening to the Brewy with a little ultrasound over the superior ophthalmic vein. And I put Ron did the cut down. I put the catheter up, put it in the cavernous sinus, blew it up, pulled it back. And man, it was like a charm. That Brewy just disappeared. And there was a whooping and hollering and high fives. So we sewed it into place, and everything was great. The thing Prolo and Hanbury didn't mention was that it's a semi-permeable membrane. And after a few weeks, it started to collapse. Yeah. So the Brewy came back. Not as loud, but it was there again. So had to do something else, and needed to put some plastic up there something that would freeze and not leak out. And I did some more research. There was a thing called HEMA out in California, but you couldn't get it. But I found a guy in Baltimore. He did facial prostheses, cute little old guy, this beautiful little custom shop. And he explained about this plastic he was using. It sounded like it might work. So I tried a little bit of it, looked like it might. So I brought some of this back, practiced with a TB syringe. Then we took the kid back to the OR, cut down on the carotid, got out the catheter again, straightened out the shaft. I took a TB syringe with this plastic and a TB needle and put it onto the shaft and squirted in the plastic. And the Brewy disappeared again.
Wow.
And that time it stayed gone. And it fixed the kid. He wrote me about 10 years later, sometime when he was in his 20s, again, thanking me and how he was doing really well. So it was kind of the Wild West. You probably couldn't do that today.
Probably not. That's incredible. I mean, what a great ingenuity. I mean, I love how you guys were thinking outside the box and trying to figure out what new materials would be available and what you could use in different situations. Wow, that's crazy. And then, what happened after Maryland?
I wanted to learn German. And so Rosemary had emigrated from Garmisch-Partenkirchen to Boston because she wanted to study physics at MIT. And so I wanted to be able to talk to her half of the family. And so we decided we'd go to Europe for a year so I could learn German. And so I had 4 criteria. I wanted to be in a good academic center. I wanted to speak German. I wanted to ski a lot. I wanted to drink a lot of beer. Those are the 4 criteria, not necessarily the order, but those were the criteria. And I also wanted to learn neuro because my training had really been totally inadequate. And at the time, the best textbook was by on cerebral angiography was by Yashergill and Kryenbull. I didn't even know that this time that they were neurosurgeons. They were at the Kantonsspital in Zurich. That's sort of like Switzerland's Mass General. And so Yashergill was there. Now, Ghazi Yashergill may not be familiar to body interventionalists. He was, without question, I think, in anybody's mind, the best neurosurgeon on the planet in 1975.
Wow.
The Journal of Neurosurgery, when they talked about neurosurgeons of the half century, the first half century was Harvey Cushing, and the second half century was Ghazi Yashergill.
Wow. And he was right there. You were there.
He was at the Kantonsspital, yeah. And that's why I wanted to go there. Now, I had a good moonlighting job, and the head of Prince George's Hospital in Cheverly, Maryland, where I was doing that, was Bill Stecker. And he had been at the Kantonsspital. He knew Professor Wellauer, and he got me the job there with Wellauer.
Wow.
So we go off to Zurich for 16 months. I was going to work for 12, and it was 2 ski seasons before and after.
Dave, I like your style.
So I was going to be doing all the diagnostic procedures on Yashergill's patients in 2 different rooms. No neurointerventional at that time, of course.
Right.
And we didn't even have a CT scanner. The only one in Switzerland was an ME scanner in Basel. Drove Yashergill crazy. But we were doing the typical invasive procedures of the time. And you think about this now and you think, holy cow. Like I did pneumoencephalography on the Siemens Mimer 3, which you've never heard of.
Yeah, no.
This thing was a very sophisticated, huge device. It looked like an electric chair. And you would strap a patient in, just like in an electric chair, arms down at the sides and legs and abdomen and everything. And you'd stick a needle into the lumbar space. You'd do a lumbar puncture. And you'd squirt in 40 cc's of air, which was a standard amount for pneumos. And then you could rotate this thing in any plane. So you could turn the patient sideways or upside down and sideways, all the time with a needle in their back. And then you could do tomography in any plane to look at the ventricles. Fortunately, Yashergill wasn't very fond of pneumos, so I didn't have to do many because I was never any good at pneumoencephalography at all. Myelography was, they had water-soluble contrast. It was the first time I'd seen that. We didn't have that in the U.S. yet. Cerebral arteriography was really interesting because Kryenbull, when he was head of the department, Yashergill was now the head, and Kryenbull was retired. He had Yashergill doing cerebral arteriography for 10 years, and also in the lab, which is where Yashergill worked out all his very fancy, elegant techniques. So Yashergill was very hung up on direct sticks. So everything I did there initially was direct stick. And I did hundreds of these things where, like the workup for an aneurysm. So patient would come down, they'd be put in anesthesia. I'd do a direct stick in one carotid, a hand inject. And if that was negative, leave needle in place, stick the other carotid, hand inject. If that was negative, pull the needles, get hemostasis, wake the patient up, send him upstairs. Come down the next day, put him asleep again, do a retrograde brachial arteriogram on the left. Now, this is where you'd stick a big needle into the brachial artery in the antecubital space. And then you'd machine inject this at a high rate of, I think it was around 25 cc's a second.
Wow.
And that would reflux up the subclavian and fill the vertebral, and you get a shot at the of the posterior fossa. And if that were negative, then you'd do a retrobrachial on the other side. And that would be how we would do a workup. There actually, I never used one, but there were some specialized needles they developed for doing direct stick vertebrals. I'm not making this up. And I have to admit, I actually did that on a couple of occasions when I was trying to stick a carotid, and selective vertebral came up. Fortunately, I didn't hurt anybody with that. But eventually, I accumulated enough cases that I had done both a catheter arteriogram and a direct stick. And I accosted Yashergil in the hall one day with his entourage and said, "Hey, can I show you some things here?" And so I just showed him. He didn't say anything. I just showed him one case after another. I said, catheter and direct stick, catheter, direct stick. And he just held them up to the light in the ceiling. And they were clearly better, the catheter ones.
Right.
And also you could do the whole procedure in one sitting. So eventually he bought that, and he said, "Okay, do it whatever way you want." And that's how they started doing catheter arteriography at the Kantonsspital.
That's great. So you're actually bringing new techniques to them.
Well, a little bit. Now, I also did a lot of translumbars because I was interested in peripheral arteriography as well. We did high sticks there. You either stick below the renals like I was used to doing, or you stick above the celiac at the junction of the thoracic and abdominal aorta. And so I did a lot of those.
Wow, that's quite some time ago. We don't do that,
oh yeah,
that much, fortunately. Wow. So what happened next? I mean, you got really good at skiing. How was your German at this point?
Oh, my German got better. I actually gave a couple of lectures in German, believe it or not. We had about 8 different nationalities. I wanted to give some lectures. And the first one I said, "Okay, I can give this in good English or bad German. What do you want?" And a couple of the Greeks were pretty weak in English. So I lectured in German about bone pathology.
Nice work. Well, this leads me to my next question. You also did an exhibit at the 1976 RSNA on balloon angioplasty. And how did that happen? Tell us a little bit about that.
That was one of the most incredible bits of luck. I still can't believe it happened, but I was between cases one day. And so early on, walking down the hall in the Röntgen Institute, walked by the place where they were doing the angios. And on the monitor in the room, I could see a catheter down a leg. I knew it had to be an angioplasty. So I walked in and said, "Hi, mind if I watch?" Because I'd never seen one. And so he says, "No, come ahead." So so he put the wire through, and then catheter comes down. Okay, I understand that. But then a balloon goes up. Ooh, I didn't know they were using balloons now. It turned out that was the only place in the world that was. And so the balloon then, after a while, goes down. Catheter comes back, squirt, arteries open. Really cool. Wow. So the guy's taking off his gloves, and I said, "Gee, that's really neat. I'd never seen an angioplasty before. Hi, I'm Dave Kumpe." He says, "Hi, I'm Andreas Grunzig."
Wow.
And I said, I'm going to be here for a year. I've never been in a place that did angioplasty. I'd love to learn. Would you mind if I worked with you? And he says, "No, come ahead." Wow. So that was 1975. For those of you who don't know, these two do, but if you don't know, Andreas Grunzig made practical balloon angioplasty, and also invented coronary angioplasty and built a balloon. And but in 1970, that was later, and in 1975, nobody knew who he was. Now, I think Grunzig was as important as Dotter in getting IR started.
It wasn't 78, I think, when he did the first public.
No, it was September 16th of 77 on Adolf Bachmann.
Yeah.
But Grunzig was a real interesting character. He's an East German. It was a rather difficult personality, very single-minded. Nobody in radiology liked him. I was the only one in radiology who worked with him. He had some training in internal medicine and vascular surgery and in epidemiology. He was interested in coronary artery disease, but he was not a cardiologist and had no training in it.
Interesting.
He was interested in vascular disease. They got these big clinics over there called angiology departments, where they get a lot of they have a lot of smokers, so they had a lot of peripheral vascular disease. And Grenzig started doing angioplasty with the bougie technique, Dotter's bougie technique. He learned that from Eberhard Zeitler, who learned it from Dotter. And the procedures on the schedule were scheduled as Dottern, Dotter with an N at the end.
Yep.
And so whenever I saw one of those, I knew Grenzig would be working. And then Andreas's original angioplasties, while he was trying to figure out a balloon, were bougie technique, and he did a fair number of those. But everybody knew that you needed a balloon because you couldn't treat bigger vessels. And nobody had been able to make a practical one.
Right.
So Andreas set about building a balloon. And now Switzerland's MIT, the ETH or ETH, is right across the street from the Kantonsspital. So Grenzig went over there and walked in and says, "Who knows about plastics here?" And they say, "Oh, you want Hopf down at the end of the hole there." So Grenzig goes to Hopf, tells him what he wants. Hopf says, "You want PVC?" And Grenzig says, "What's that?" And Hopf says, "Polyvinyl chloride. You're going to love it." So now Grenzig took this idea from Hopf, and he worked this just on his kitchen table at home and on Maria Schlumpf's kitchen table, his technician.
Yeah.
They built over 100 different prototypes before they finally found something that worked.
Right.
And so what worked was this, that he took a sleeve of polyvinyl chloride, and they'd be anywhere from 4 to 8 millimeters in diameter. Polyvinyl chloride has the property that when you heat it up, it shrinks. So he found an engineer who could carve a groove down the outside of a straight angiographic catheter without getting into the lumen. So he took that kind of catheter, he took a PVC sleeve and put it over the catheter, and then he took a heat gun, a hairdryer, and right at the tip of the catheter, he heated it up so the PVC shrank. And then he left a blank space where the balloon was going to be, and then he heated up the rest of the PVC sleeve, and it shrank against the shaft of the catheter. He figured out a way to do a dual port entry at the proximal end, so you could both inject the catheter and inject contrast in the side port, which would go down the groove and fill the balloon.
Right.
He figured out a way to glue the PVC to the tip of the catheter. He said that was hard. And
I can't.
and so and he had then and he tried some of them, and the damn things worked. They had terrible tips. You couldn't put them into an artery very well at all. We didn't have sheaths.
Yeah.
But boy, when you got them there, they worked. And now Grenzig needed balloons, but he didn't have to. He's going 17 directions at once. He hadn't have time to make them. And so he needed a manufacturer, and this is one of the biggest black eyes of the Cook Corporation. Cook was the biggest outfit in Europe, catheter. He goes to Cook and says, "Hey, could you guys make this catheter?" And so he's explaining what it is to a number of the Cook people and explaining it. And after a while, the answer is, "Das ist einfach unmöglich. Man kann das nicht machen," which is, "That's impossible. You can't do that." And Grenzig said, "Wait a minute. I just told you how to do it. I told you what to do." And the answer to that was, "Das ist einfach unmöglich. Man kann das nicht machen." And so Cook lost out being the first company to have a balloon. And so Maria volunteered her husband, Walter Schlumpf. Now, Walter was an engineer. It had nothing to do with plastics or catheters or medicine. I don't know exactly what kind. But bright guy. And so Grenzig showed him how to make these things. Now, Walter had a day job. And so he would come home at night and go down in the basement and make these things at night. Wow. And then we would throw them into Sidex and put them into patients. And that the entire year that I was there scrubbing with Andreas, these were all handmade balloons by Walter Schlumpf. And wow. I scrubbed on all the angioplasties Grenzig did that year, along with Felix Mahler. We came back in April of 76. And I was just getting started with my academic career, wanted to do something at RSNA and decided to do a poster and do it on angioplasty. And I was too stupid to know how much work a poster was at that time. It was a lot because no computers.
Right.
And so we made up 12 cardboard panels, very elaborate.
Right. Wow.
Now, Andreas' habilitación. So when you don't just join a medical school faculty in Europe, certainly not in Switzerland. You have to do essentially a PhD thesis, and that's called a habilitation. Andreas was absolutely meticulous about follow-up of all of his patients. He kept in touch with them, and he was using vascular lab data, SLP, submedullin pressures and pulse volume recordings, SLPs, PVRs. Sure. And so he had those. He did follow-up arteriography on something like 80% of his patients at 2 years. And so he had the data, and he did this habilitation on all of his data. And so he wanted to translate. It was published in a little book in German, and he wanted to translate it in English. And he asked me to do that. So Rosemary and I did that. She translated it into English, and I translated it into Medicalese. And I don't have that book or this was when I was at the VA in 76, and Gert Swenson typed it up, and I can't find that stuff now. It'd be historic. But anyway, I had all this data. So this poster was gorgeous. It was 12 panels. It had the catheter, described the technique, showed some early cases, claudication, some limb salvage cases, had all of the data, initial results, follow-up data, complications. I mean, it was absolutely exemplary by today's standards. Yeah. And this was the first public demonstration of balloon angioplasty to the American radiologic community. Okay?
Wow.
Now, this idea changed medicine. This was revolutionary.
Absolutely.
And it got no attention.
Was it in a dark corner at RSNA?
No, it was right out in the middle of everything else. The prize that year, I still remember this, was done by Rogelio Moncada. He was, I think, the chairman at the University of Illinois. And what he did is he poured red cells in the contrast material and looked at them under a microscope and showed that they crenated. Oh. So that was held to be the most important scientific advance of 1975 at 1976 at RSNA. So I kind of understood Dotter, his crying in the wilderness for so long. John Abley did see it. Dotter saw it, Bill Casarella, a couple others. Abley made a picture of that exhibit, and many years later sent me a framed picture he took of it with a nice little plaque at the bottom. Abley is the guy who started Meditech that became Boston Scientific. He's the only billionaire I know. But now this becomes a very good story for residents. The first person, the guy who does the work usually is the first author. And Andreas didn't even know I had done this. I just went and did it. And so theoretically, I should put myself as first author because I did that work, but I wasn't about to do that. This is all Andreas's work. Right. So I listed the authorship as Grunzig, Kumpe, Mahler, and didn't think about that. So a couple of months later, somebody told Andreas, that was a nice exhibit you had at the RSNA. He says, "Was?" He said, "Oh yeah, there was that exhibit with David Kumpe and Felix." And Andreas's first question was, "Who was first?" and so they told him, "Well, you were." And so he knew that I was intellectually honest. Wow. Okay, now this gets more interesting. The first coronary that Andreas did was, as I said, Adolf Bachmann, September 16, 77. He's instantly world famous. Unfortunately for Switzerland, fortunately for us, the chief of medicine at the Kantonsspital, Walter Siegenthaler, just didn't like Grunzig. He was not easy to like and really tried to hold his career back. And so Grunzig said, "Okay, I'm out of here." And he went to Emory in early 1980 and started their angioplasty program there.
I was wondered how he got from Zurich to...
Well, it was that. It was Walter Siegenthaler. And just trying to, he just couldn't get done what he wanted to do. And he had a real clear vision of where he wanted to go. And Siegenthaler was just standing in the way. Everybody wanted this guy, but one of the things Grunzig insisted on, he wanted to be a professor. Mm-hmm. And that was a hang-up in some other programs. And Willis Hurst was willing to do that for him. They actually had to do something with the state legislature to get that done. But they got it done. And so Grunzig was there. And I had seen him in a number of different situations, and he was really creative and better getting out of trouble than anyone I ever saw. And there are a number of stories about that, but in the interest of time, we'll go on. But I think I'm probably unique because I have been on both sides of the catheter with Andreas. Remember, it's always better to be the herder than the herdee. But
wait a minute, what? You've been on the side?
yeah, I was so 83. I was really fit, and I got interested in biking, and I was going to do some bike racing, and so I had my bike on a trainer in our garage. In January, and it'd be about 35 degrees, and I'd be out there pedaling, and I get this retrotracheal ache. And the first time it happened, I'm 41 years old, and the first time it happened, I said, gee, I wonder if that could be angina. Nah, couldn't be that. I had no risk factors, and boy, I was really fit at that time.
Right.
And so I let it go for a couple of months, and how stupid and denial you are. I mean, a couple of times when I was riding, it would go down my arm and center my wrist. And I finally decided after a couple of months, well, gee, maybe I ought to get this checked out. And of course, I had a 4+ positive treadmill. And I didn't want anybody but Andreas touching that catheter. If there was any trouble, I wanted him figuring out what it was. So I called down there. It usually was a couple of months, but I got an appointment the next week.
Wow.
And so Andreas did the arteriogram, and at that time it wasn't find it, fix it. He'd think about what he wanted to do, and then the following day do the angioplasty.
Gotcha.
So I had an isolated 98% narrowing of my LAD.
Wow.
But I found out later it was called a widowmaker. It's the same lesion that Adolf Bachmann had. Yeah. And so next day, I'm supposed to have the angioplasty, and Rosemary's there. And my case got bumped because there was an emergency. So Rosemary and Andreas and I are just sitting in a room waiting for this case to finish. And so I'm asking Andreas, why me? What's going on here? I don't have any risk factors. And Andreas says, it's the arterial flu. I said, what? Andreas says, it's the arterial flu. I said, Andreas, what the hell are you talking about? He says, those risk factors, diabetes, hypertension, lipids, family history, and so on, those are not the causative factor. Those are exacerbating factors. The cause is the arterial flu, and you had the arterial flu. Now, that was 83. And so subsequent to that, all this stuff has come out about inflammation being the initiating thing with atheromatosis.
Right.
But he was just way ahead of his time.
Absolutely.
And I've had no further problems. He popped it open, no stent or anything, and I've had no further problems with coronary disease ever since. So It probably was the arterial flu. So now this is a story I tell to the residents as why you never, ever, ever take credit for somebody else's work.
Right.
Because just think, suppose I put my name as first author, after all I'd done the exhibit,
Exactly.
and now I needed Andreas to save my life. So
I see a serendipity, like this theme of serendipity with you, Dave, kind of coming over and over and over.
I mean, I've been so lucky all along the way. And a lot of the early developments in IR came from Europe, and I got to meet a lot of the early drivers of that, particularly in vascular disease. Zeitler, Laszlo Horvath, von Andel, Olbert, Klaus Matthias. Right. I also got, I'm going back to neuro for a minute. I went over for a week, spent a week in Paris with René Gingin, who was the guy who was the guru and pioneered spinal arteriography. So a great experience over there.
Wow, my goodness. How lucky. I mean, you saw an opportunity and you took it.
Well, you'd rather be lucky than good, and I've had much more than my share.
That is fantastic. Wow. Anybody else in North America at that time that you were?
Well, see, Dotter was in 63 in Prague at a conference. Dotter said that used with imagination, that famous quote about used with imagination, the angiographic catheter can become a surgical instrument and we can treat disease conditions. He got a standing ovation at that conference. And at that time, there were a few places that people were doing individual stuff. There was Dotter and Rush at in Oregon, and then Kurt Amplatz and Stan Baum, and then Stan Cope in Philadelphia, and probably a couple others, Berhenny in Vancouver. Mm-hmm. But this was all just individual little procedures that were being done at that place. And IR really didn't exist as a specialty.
Yeah. Wow. So can you kind of unpack a little bit for our audience how IR started in the U.S.? I mean, we kind of have these different sort of, luminaries of the field in their own individual departments doing their own thing. But how did it start across the U.S.?
Well, that's why I think Grunzig is so important, because in 1978, for the first time, you could buy a balloon catheter. You could get a balloon catheter, and you could fix vascular disease. And that was the springboard to me that you could start doing cases first in vascular disease, but then that got people thinking all over the country, angiographers, what else could we do with a catheter? And that very shortly brought in some of the other work being done in livers and kidneys and so on. And IR is really interesting as a specialty because it's the only specialty I know of that, other than interventional cardiology a little later, that it started all over the country as an organized specialty in a very short prescribed period of time. And it would individual people in all the different centers. Mm-hmm. I was the first one in Colorado. When I got here, I said, this is what I want to do. I don't want to read x-rays. And but before then, in Denver, Chuck Seibert at Swedish, Neil Goodman over at St. A's had done an occasional interventional procedure, but mostly they did nothing but diagnostic arteriography. The time just wasn't right. So once I had that balloon catheter and got started with that, I got to start IR as a specialty in this the whole Rocky Mountain region. I was the first one. And what I was doing here was people all over the country did that at their various medical centers. And we all had the same problem that there wasn't any senior experienced partner who can tell you how to do this or teach you how to do this. We're all doing things for the first time. And so it was just, somebody who'd done a couple of cases. So you call them and say, how do you do with us? And so, I mean, I did the first tips here, and I knew in general what a tips was and how it was done. And Jan was going to be doing those, and she had done all the preliminary work, but she happened to be out of town when this first case that needed it came up. And so I had to do it. And so I just called up Irina Van Breda at Fairfax Hospital in Alexandria. It's now Inova. And just say, hey, Irina, how do you do a tips? Because I knew she'd done a couple. She said, oh, it's simple. Here, let me tell you. So she told me how to do a tips. I went and I did it. And that's how all those early cases kind of went.
Wow, that's right. I mean, you had some tools in your handbag, and then you just do it. You call the people who've done a few and learn from there.
Yeah.
Well, how did you get to University of Colorado from Zurich?
Well, I really wanted to be in Colorado. I had an offer to go back to the MGH after finishing NIH. But in the Harvard system, you're expected, they want you to develop an area, and they wanted me to develop their parathyroid program. And I'm quite sure, had I gone back there, by now today, I would be, without question, the premier parathyroid arteriographer on the planet. Whoopee. But I wanted to be in Colorado. It took a year to get here, and I couldn't have come into a better situation. It was just so different from what most guys faced.
Right. Because you've got good skiing and cycling here. I mean, it seems to make sense. But when you came here, did you have any opposition at Colorado? I mean, you're a new guy coming here from the East Coast in Europe.
Well, actually, it was more the idea of doing interventional, because most of my colleagues in other medical centers, or at least an awful lot of them, ran into a lot of resistance. There was the surgeons weren't real happy about it. Hal Coons is at Sharp Hospital. He's my vintage, and he tells a story that sort of crystallizes that. He says, "Well, you got a surgeon here, and he's making a really good living his whole life doing this procedure. So you go to him and you say, I've got this thing I do. It does the same thing as your surgical procedure. It's much easier on the patient. I can do it as an outpatient. The patients like it much better. They don't get cut open, and it's cheaper. What do you think?" And Hal says, "You can't expect the guy to say, 'Thank you. I'm so glad I know that.'" And that's really what the story was, that there was a lot of concern about these procedures replacing surgery.
Mm-hmm.
And Colorado, they were really weak when I got here in catheter angiography. Derek Stables was here doing GU diagnosis, and he was doing some nephrostomies, and I learned that from him. And at the U, people saw the other surgeons saw that in vascular I could do what I said I could do, and they started listening to me when I said, hey, I could help you with this or that, and they started sending cases. In that period from roughly 78 or so to the late 80s, it was just almost like a procedure a week. It was just an explosion of new procedures, and I was always looking for something new in different areas. What's a tube and what can I do with it? And livers, kidneys, aorta, the fallopian tubes, dialysis, lysis, tumors, embolizing, AVMs, and so on. And what's the toughest thing you can do with a catheter? And I was known to be pretty aggressive. And there was this one time these two surgical residents came down with a case, and I said, no, there's some things you can't fix with a catheter. And they really wanted me to sign a piece of paper that I'd actually said that. But I was able to do a lot of, we were the first doing stuff. And so I was able to start a lot of new procedures in Colorado. I got this list somewhere of more than 40 things I did for the first time that was done in the state. It was done at the U, not the first time in the country, but I introduced it to the state. So in one sense, I really got to spearhead the development of IR in Colorado.
Wow, that's really fantastic, Dave. I mean, you just listen to you tell these stories. I mean, and I'm reminded about that in my current practice. And our surgeons and our patients really rely on a good IR to be inquisitive and curious, and really, take appropriate risks when necessary to really kind of push boundaries. And the things that we can do with a catheter through a small incision or even no incision sometimes now is really, really remarkable. And that kind of leads me to my next question is like, well, I mean, we all seems like we're spoiled now with all this great equipment, but what was the angio equipment like at that time when you in the 70s and 80s?
Oh boy, is that a setup. You have no idea. You don't think about digital, but digital came in sometime in the very late 80s or early 90s. Mm-hmm. And before then it was film, and that was awful because sometimes you couldn't do just a quick squirt of contrast and see where you were, and you needed to do an angio run. And the regular angio runs were on 14 by 14 films. You do a run, and then initially the films would take 3 minutes each to develop. Wow. So there was this big long pause while you would have a run of 15 films come out and put them up on the view box, then look to see what you did next. We eventually got processors that did that in 90 seconds. That was a big improvement, but there was still the pause. There was these little spot films that would be a long, continuous roll of films, and the pictures were about maybe 8 centimeters across. And those you would be just developing one film. So we did a lot of spot filming. You take subtraction for granted. I don't know if that many people these days know how subtraction was done initially. It's done electronically in the same way now, but you would take if you wanted a subtraction, the tech would take the mask. So you'd have a blank, before any contrast. Right. Take that into the dark room, shine light through it, and you get a reversal onto a film. Mm-hmm. And you take that mask, then hold that up and line up with the film you were going to subtract until you got as rid of as little misregistration as possible, and tape the film together, and then shine a light through that onto another film. And that would be the subtracted film. Wow. So this was a very elaborate process and took the techs a lot of time. There were some techs who were really skilled at it, and they were precious as they could be.
I'm sure.
But you think all the complex things we do now, and you just couldn't do that with film. So digital was really key.
Right. I mean, it's not only is it just shortened the procedure, but it's really expanded dramatically what we can do. Right. And how long did a standard angiogram in that era take?
A carotid would be probably an hour, something like that. I remember Bob Breeze, when we started working together, he was used to having the neuroradiologist do the angios, and they kind of struggled. And he was there once when I did one, and I did 4 vessels, and we were talking about the results and everything. And after we finished talking about that, said to someone else, he just did those 4 vessels in 12 minutes. And Bob wasn't used to that. So he figured out I could use a catheter.
Right. That's good. And speaking of catheters, what about the angio tools then, catheters and wires?
Well, it was all just standard angiographic diagnostic stuff. The balloon catheters were very primitive. They were all 8 millimeters or less, no stents. We had gel foam for embolization, eventually got PVA. When we started lysis, it was S-streptokinase.
Right.
And so we were just using these simple tools in different organ systems and try to use them in different ways. And then we finally started getting specialized wires and catheters and stents. I mean, the Kumpe catheter wound up being useful in a lot of different ways.
Right. Yeah. I mean, I think this is like the point of what everybody's like wanting to ask, wanting me to ask you about this. I mean, like the Kumpe catheter. I mean, it's such a staple, in our armamentarium. I mean, it's our go-to catheter for so many cases around the world, probably. Tell me about how did you come about developing this specific catheter? It became known as the Kumpe catheter with your name.
Oh, there was a lot of research that went into that over many years. Yeah. So the story was that when I got back after the Kantonsspital, most of the angioplasties that we did, or at least a great deal of them, were SFEM. And so you had to do a downhill stick. We didn't go up and over then. And so doing a downhill stick, so of course the needle is pointing down. And in the common femoral artery, the profunda comes off posteriorly. Mm-hmm. And so it was hard to put a wire into the SFEM because the stupid wire kept going into the profunda. So sure. I really wanted some way. Again, we didn't have steerable wires or good catheter or anything. So I needed some way to get into the superficial femoral. So I just talked to Cook and said, hey, could you make up a short little catheter and just put a little hook at the end? And so they made up a couple of them, and it worked. I could put the thing into the profunda and then just pull it back under fluoro and point it up and squirt. When you saw the SFEM, then shove in the wire.
Right.
And so they started making the Kumpe catheter for us, and we were using it at the VA and in our shop. And I was using it for that purpose. And I was talking to the guy at the VA one day, and he said, this thing's good for a lot of other stuff too. I said, oh, really? And he said, oh, yeah, it's good for livers and kidneys and all sorts of stuff, even iliacs. And so I said, okay, I'll try it. And sure enough, it was. And so Marshall Hicks was one of my early fellows, and he liked the catheter. And his first job was with Dan Pikus at Mallinckrodt. So Marshall shows the catheter to Dan. Dan was running some national conferences, and he really liked the catheter. So he would hold it up at his conferences and say, hey, this is really a great catheter. You guys ought to start using it. And so the word gradually spread. And the Cook guys told me, a number of years ago, that it is the top-selling catheter in the world. But all those years of development that it took,
Again, serendipity. You were like in the right place at the right time.
Yeah, and made the right guess without having any idea how useful it was.
So maybe some people are also asking about the Berenstein catheter, is very similar catheter. What was going on between the two designs there? Can you explain maybe a little bit?
Alex at that time had there wasn't torque control of catheters had lousy torque control. And Alex had USCI, I think, make up a 7 French catheter that was tapered to 5 French over the distal 10, 15 centimeters, and then put a little hook at the end of it. And that came out, I don't know, I think they both came out around the same time. I think maybe the Kumpe a little beforehand, but I just don't remember. Wow. The Berenstein catheter sort of was a staple of neuroangiography until we got decent catheters like we have today. And so then they started making the Berenstein without the 7-to-5 taper, and they started with the same angle tip. They then started to shorten it for some things. And so it basically is sort of a longer version of what I had as a shorter version. And the way Cook and Angiodynamics make this thing, and I don't know, somebody else probably does too. And the companies go up to about 65 or so.
Yeah, exactly. Speaking of neuro, you've done INR actually for many years. And how did you sort of morph into that? I mean, you had a great career in body IR, brought a lot of great procedures to Colorado, and obviously made a name for yourself there. But how did you sort of morph into an INR?
Well, it started out with stroke. And this was 1988. And I came into the department one morning. And just as I'm coming in, there's this overhead page. Dr. Kumpe, will you come back to the angio suite? So I go back there, big long line of films on the view box. And Glenn Kent, the chief of neurosurgery, is there in the control room. So this is a young guy in his 30s somewhere, and he'd been whapped up the left side of his neck in a bar fight, and shortly thereafter had gone hemiplegic and aphasic. And what these films that they'd done showed was that he had almost totally occlusive, but not quite, clot at his M1, M2 junction. And Glenn Kent was there, and he was an aggressive guy. And so he told the neuroradiologist, gee, this guy's going to do bad. You should put some urokinase up there. And the neuroradiologist said, call Kumpe, he'll do anything. So hence the page. So I knew about UK being used for strokes. I was vaguely aware of a couple papers. I never actually read one of them. And at that particular point, as I went back, there were about 20 some cases in the literature and only 4 reported from the US. So I go back there and Glenn said, tell me, you should put some urokinase up there. And I said, gee, don't know. I never put urokinase in anybody's head before. He said, this guy's going to do real bad. So I said, well, okay. And I didn't have any microcatheter, and I had no idea of dose. So I just put a catheter in his internal and started the standard dose, 250 an hour, and was running it. And this is still one of the most dramatic things I have ever seen in my career. So they'd gone into the right side. It's a left carotid, so right side's paralyzed. And after about 50 minutes, I can feel the guy moving his hand under the drapes. What? And at an hour, he had a normal strength grip.
Wow.
And this thing wound up being a total home run. Had a couple of kids and everything. And
Lazarus.
we fixed a stroke.
That's fantastic.
And I did another one. Within a couple of months, they sent me another one. And it was a basilar occlusion, long basilar occlusion. And the guy was comatose. I got the thing open completely. It was a beautiful angiogram, but he remained comatose. It was just too late.
Yeah,
but it was proof of concept, and I took it. I took it to the neurologists. I went into one of the grand rounds with these couple of cases and said, "Guys, we can treat stroke. We can treat stroke." And I made the strategic error of mentioning quick and dirty physical exam, and which became the NIH stroke scale, and 2 in the morning.
Wow.
And there was zero interest. They just were not interested. And it wasn't until the mid-2000s that we finally got our stroke program going. It kind of sputtered along before then. But that got me interested again in the head. NIR in the early 80s, or actually even late 80s, was a real young specialty. And Grant Kishima came to town and talked at the Rocky Mountain Radiologic Society later in 88. And that's the first time I'd ever seen him showing some of the stuff he was doing. I was blown away. I thought I knew everything. I was pretty arrogant at the time. And this was stuff I just didn't know. And so I got interested in this, said, geez, I want to look at this. And there weren't many places you could go. I went out to Grant's place at UCSF for 2 weeks. And there were only a couple. I mean, Grant was one. Chuck Kerber was at Pittsburgh, went to UCSD. Alex Berenstein at NYU. Bob Ferguson was in Tennessee. And maybe 1 or 2 others. But basically, there wasn't very many places out there doing anything. So anyway, I went to Grant for 2 weeks and watched his cases and thought, man, this is cool. I want to learn this.
Nice.
And I knew I had to get updated the techniques. And so I had to take a sabbatical. And Grant wanted me to come for 2 years and said, Grant, I just can't do that. Look, I'm a full professor. I'm head of the section, and I just can't take that much time. The most I could do was 6 months. And Berenstein was agreed to have me come for 6 months. And by that time, Jan was at our place, and she'd been there a year or two, and she was just fantastic. She was superb. Wow. And so we talked about it, and we both decided together that she could handle the service for 6 months. So I went off to Alex for 6 months and watched his cases, and not exactly the 2 years that trainees do these days. But I learned what I needed to know and got back, started really slowly with cases, and only took stuff I thought I could handle.
Smart.
Then there were another couple people in town that were also starting at the 2 other hospitals at exactly the same time as Bob Siegel and John Whitaker over at St. A's and Wayne Yates at Swedish. And we would occasionally scrub together on some cases and sort of learn together there.
Interesting.
But in neuro, it's different. I gradually got more comfortable, but they're scary cases.
Right.
And it was just me and NIR, and around 2000, I had so much neuro business, I finally had to pull myself off the body schedule. But I also figured that my other partners, if I tried to hang on to like stent grafts and all the cool procedures, neuro and body, somebody was going to shoot me. So better leave the body stuff to my partners. And very quickly, like a number of years later, I realized I couldn't do body IR anymore. I was out of date. Wow. I knew the diseases, not the widgets. It moved that fast, and I couldn't do body IR. So, I mean, it was pretty embarrassing. I was a CAQ examiner for many years, and I can't do it anymore. The field really moves fast.
It sure does, doesn't it? That's amazing. So you retired, though, recently, right? And
yeah, I was retired. I had choice of timing was not mine. Most vascular neurosurgeons stop operating by the time they're 60 or 65. And I was 77. And there's some concern that people start looking and saying, isn't this guy getting a little long in the tooth to be doing this kind of stuff? And I'd already backed off doing aneurysms about a year, my last year. But it's better to go out while there's still some cheers in the room. And it was a great year, a great 42-year career, 43 now because I'm a professor emeritus, and had just a great career there. It occurred to me somewhere along the way that almost never does an academic doc get to start an entirely new program that didn't exist and then have that become totally vital to the function of the hospital. And at Colorado, I got to do that twice with both body IR and then neuro IR. And man, I just talk about being in the right place, right time, and having that opportunity. When I retired, the chairman created this David Kumpe endowed chair of radiology, which cost the department $2 million. That was really satisfying. I was really happy with that.
Yeah, well done. Yeah, there's where I came from, and there's a daughter chair also, and I think that's important for.
Yeah, you came from the fountain.
Right. It's important. These endowed chairs are very important for honoring your legacy and your contributions to the field. Things that we all unfortunately take for granted in our daily work. But it's been really, really enjoyable, talking to you today. One last question I have for you, Dave, is about Western Angio. Obviously, with COVID, we're not going to be at Western Angio this year, and we're all pretty disappointed about it. But I just wanted to ask you what your impression is with Western Angio and Interventional Society. What does it mean to you as a meeting? I mean, we have SIR, we have CIRSE in Europe, and there's 1,000 meetings, and there's ski meetings, as you talked about earlier, which are very important to me too. But what is it about Western Angio? What's the secret sauce to that meeting that you really enjoy?
Oh, that's one of my 2 favorite meetings. It's the oldest society. And my first one was actually the 26th annual in 96 in Hawaii. Nice. But it's a manageable size. It's growing, and I hope it doesn't get too much bigger. It's always in a nice location. Right. It's got the topics are usually more practical. I learn more going to Western Angio. There are a lot of how I do it type talks. And the talks are long enough that you can go into things a little bit more, and they're flexible how long the talks are, depending on what the topic is. Then during the whole meeting, there's time to talk with some of the attendees. You get some questions about this or that. You have time to talk with the guy who gave the or the woman who gave the presentation. Right. And then there are these different social events where you get to talk with people more, and you get to know people, and you see them year after year. Right. And so you kind of grow old together. It's just, and it's got just a great atmosphere.
That is absolutely true. I mean, that's why I really enjoy going back every year. I'll give a lecture here and there, but I really enjoy seeing my old friends and meeting new friends too. And new colleagues from around the country. And it's not just West Coast now. There are some people from the East Coast coming in now occasionally. Yeah, like Aaron Fishman from Sinai. Met a few years ago in Hawaii. So it's a very special.
But don't tell too many people about it. We don't want the damn thing to grow so big.
I know. That's the thing, right? We want to keep it to ourselves. Absolutely. Well, Dave, I just want to wrap up here, and I just really appreciate you coming on today. I knew you would be a great guest for the show. Because first time I met you, you may not remember, but it was at a dinner at the French restaurant Mizuna here in town, and I had taken my wife out for a nice birthday meal, and we ended up sitting next to you and Rosemary, and we had just the most enjoyable conversation that night, listening to your stories, and I knew you had a lot to tell. So, thanks for unpacking some of your history and experience with interventional radiology and your contributions to it. It's been really wonderful talking to you.
Well, I've had a great time. Really appreciate very much the invitation to do this.
You bet.